Hi, my name is Jacob Gluski. I'm an M4 at Wayne State University, and today I'm going to be talking about a case report of a patient with acute Hep B in a previously vaccinated adult who experienced fulminant liver failure. This case took place at Henry Ford Hospital, and let's jump right in. So the patient was a 32-year-old male with a past medical history significant for depression treated with venlafaxine. He was not on any other medications, nor was he taking any over-the-counters regularly. He did not have any past surgical history and had no known allergies. His family history was interestingly significant for hereditary hemochromatosis in his father. His vaccines were up to date, including a second series of Hep B because he had had low serum levels of the Hep B surface antibody. In social history, he reported himself as a non-smoker without any intravenous drug use and as a social drinker who had 3 to 4 beers a year on holidays. He did have some tattoos, but all of them were professionally done, and none had been within the previous year. He had also served 2 tours in the military, and then finally, his main risk factor for hepatitis B was unprotected receptive anal intercourse with one partner, which had occurred just prior to presentation. He did present to an outside hospital with a 3-day history of non-bilious, non-bloody emesis and worsening jaundice and abdominal pain. He also reported myalgia and some mild lethargy. The workup done at the outside hospital ruled out toxic etiologies and was significant for elevated LFTs at an AST of 3075 and an ALT of 4895. This combined with an INR of 2.0 and the lethargy actually meets the criteria for liver failure. He was notably positive for Hep B surface antigen, as well as anti-Hep B core IgM antibody, and a ferritin level over the upper level of the test at 8,000. So the outside hospital decided to transfer the patient to Henry Ford for possible liver transplantation, since Henry Ford is the liver transplant center of Michigan. However, on arrival to Henry Ford, his lethargy had actually abated, and his exam was pretty benign. He had stable vital signs throughout his hospital stay, and his jaundice and abdominal pain was actually lessening throughout the course of his hospitalization stay. During his hospital stay, he was only treated with fluids, IV vitamin K, and N-acetylcysteine. Now, a large battery of tests were actually done to make sure it was only Hep B and nothing else. All of it came back negative, except for a allele in the HFE gene, the hereditary hemochromatosis gene, that is. It was the H63D allele, and he was heterozygous for it. Previous literature review showed that this allele was not known to be symptomatic, and there were no previous reports of anyone experiencing liver failure due to Hep B with this particular allele. Here are some of his lab tests from his hospitalization. Hospital days 1 and 2 were at the outside hospital, and you can see that his liver function tests were quite elevated, but were relatively stable across days. And when he was transferred to Henry Ford at hospital day 3, they continued to remain elevated for another couple days, after which they started to downtrend back towards normal values. He was actually discharged after hospital day 8 because his physical exam was so benign. And finally, here are some takeaways and context. So studies have shown that 90% of people who get a Hep B vaccine series eventually seroconvert or develop antibodies against the antigens present in the vaccine. Of the 10% that don't respond, the vast majority of whom who receive a second vaccine series actually do develop a response. This leaves in total 1.3% of people who are chronic non-responders to Hep B vaccines. Research has shown that these are typically people with prior immunocompromise or the elderly. Sadly, our patient was neither. Our patient was likewise unlucky in that he developed fulminant liver failure because this only occurs in about 0.1 to 0.5% of cases of hepatitis B. And he didn't even have any of the known risk factors such as intravenous drug use or heavy Tylenol usage. So his case really serves as a cautionary tale that we should really adhere to testing for seroconversion, i.e. an antibody response to vaccines amongst high risk populations. We already do so for healthcare workers, and we should consider doing so for men who undergo receptive anal intercourse. And so I would like to take a moment to say thank you for listening to my talk. Again, my name is Jacob Gluski. I'm a current M4 at Wayne State University. My cell phone and contact information is listed below, and here are some references from those background stats that I gave. Thank you for listening to my talk. Bye-bye.